know that I'm passionate about aging, and I value the opportunity to talk more with you about how we can work together to promote healthy aging and open discussion about aging. Aging creates a systemic ripple effects across individuals, our families, our communities, and our industry with far reaching social implications. As adults are living longer and healthier lives, we must have a workforce that is aware of this audience's needs, their preferences, and also the challenges they may or may not be facing. Unfortunately, though, most students outside of the area of gerontology are ill prepared to meet professional and personal needs that will result from from global aging. In order to attract and prepare students in a workforce to choose careers focused on aging, uh, there is a need for them to be exposed to developmental and aging principles early in their training, to create positive and interactive learning environments which accurately portray the range and diversity within adult development and aging, and to prepare students for new and flexible positions in a growing field. Technical difficulties trying to move the slide. There you go. During today's seminar, Dr. Margrett and I will provide some information about aging demographics and ageism. In the second part, we will talk about reframing aging for us individually and as a department. For example, we may use the term elderly in our common practices, but it promotes negative stereotypes about aging. But by switching our language to using the term older adult, we can help reduce this negative stereotype. The population of older adults in the US is expected to rise from 56 million as of today to nearly 95 million um, by 2060. In addition, the age group, those age 85 and older, is expected to grow 123% from just a few years ago by 2040. Also, as the older population grows, it is also becoming more racially, ethnically, and socially diverse. It's anticipated that the percentage of older adults who are white will decrease by 22% by 2060, whereas the percentage of Black older adults and Latino older adults is expected to increase by 13 and 21% respectively. Despite a common misconception that older adults reside in skilled nursing facilities or living facilities, the majority are actually community residing and want to remain that way. I think it's also important that when we're talking about aging, that we need to recognize that the older adult population has considerable economic influence. A 2019 study by the AARP reported that Americans aged 50 years and older contribute so much to the U.S. economy that if that they'd constitute the world's third largest economy if they were counted as their own country. Given their economic power, the older adult population is helping to inform and influence the types of products and services provided across the country and across the globe. There is an ageist perception that older adults are a drain on the economy. However, this AARP study shows that as a group, adults aged 50 years and older are serving as a key driver of economic growth, innovation, and new value creation, benefiting people of all ages. This is important to keep in mind when we are developing food products and materials, health program offerings, and exploring new areas of study. Jennifer.
Thank you, Sarah. All right, if you'll click to the next point, please. I've got a question for folks. How old are you? And if we were really daring, I'd ask you to put that in the chat. But are you willing to talk about that? What comes to mind when you're asked that question? Next. Think about some other questions related to aging. How comfortable do you feel telling people about your age? Do you try to intentionally look younger? How does getting older affect how you feel about your body? Next. And how do you think you've been treated differently because of your age? Is aging different for men and women? If yes, how and why? And what about comments when people say you don't look your age? What does that mean and how could that make people feel? So if we really had a lot of time for conversation and one-on-one workshops, we could really delve into these types of questions. What really makes someone old or young? Next. So today we're talking about ageism. And this is, again, as Sarah said, a fantastic opportunity to have this conversation. And so really, ageism, unfortunately, is something that has been around for decades and even longer. So really, Butler in the 1960s brought this to the forefront. Unfortunately, we're still dealing with ageism. And I pulled a quote from the American Psychological Association. I'm a psychologist and a gerontologist, and my particular area is aging. And so happy that within the broader context of the American Psychological Association, that there's a committee on aging, and we've had now our second resolution on ageism. So really, ageism, like other forms of discrimination and stereotyping, it can be performed against individuals or groups. Here it's based on your chronological age, and it can be related to attitudes, discrimination, and institutional policies. And so as we think about ourselves, as Sarah mentioned, think about a department, as a university, what kinds of policies and procedures do we have in place? So we'll talk about some of those individual to the broader concepts. So oftentimes when I'm talking with students or other community organizations and audiences, I ask people to talk about aging, to think, what are some common thoughts about aging? And oftentimes some myths come into play. Next, please. So oftentimes people respond that getting older means decline. People are in poor health. You cannot change health behaviors. People are going to remain sick. It's a downward track. Oftentimes we have this myth about dementia and cognitive change. As we get older, we do experience normative change, but it's not normal to have dementia. Other aspects of life and functioning would be related to sex. There are common stereotypes that older adults aren't engaged in relationships or are not interested in sex. Next, please. Other stereotypes include that most older adults are depressed, that getting older means that we're lonely and alone, that it means, as Sarah mentioned, this perception that older adults are not pulling their weight, and that most people are living in, quote, nursing homes. Next. So some truths about aging. So we can debunk these stereotypes and be really conscious and find the facts when we're talking with students and when we're thinking about programs, curriculum, and research. So some truths about aging is that active life expectancy has increased. So we're not just increasing how long we live, but how well we're living. And that's an important distinction. Of course, being in food science and human nutrition, you all know that we can make changes at any age, and those ages can have positive effects. It's also, as I mentioned, never too late to learn, and dementia is not a typical part of aging. Next. Contrary to what folks think, typically older adults are not any more depressed or lonely compared to other age groups. Dan Russell, who's a colleague in human development and family studies, is a worldwide expert on loneliness. And he often finds that younger cohorts, younger ages, those folks tend to be more lonely. So it doesn't mean that just because you're younger or just because you're on a college campus or appear to have a lot of friends around, doesn't mean that folks aren't lonely. Retirees, as Sarah mentioned, definitely contribute a lot to both the economic and social capital. in our state, in our nation, in the world. Think of all the values that folks who are 50 or 60 years of age and older bring. Also, when we think about, quote, nursing homes, and I have that in quotes because really we don't use that language anymore. We have many more options for aging in place, for managing chronic conditions, for living in the home or setting of our choice. And when we do think about those options, and if someone would need a skilled nursing facility, it's the small percentage of older adults who are in that type of situation. Next, please. So during COVID, it's been very interesting as a psychologist and gerontologist to really look at what's been happening and how older adults and the perception of older adults has been handled related to COVID. So if you take a moment and think about it, you might think of the CDC guidelines related to age and risk. You might think about conversations related to healthcare and choices that health providers and families might need to make during times of scarce resources, such as ventilators. And so there's been some work done in this area. And Sarah, if you kindly go to the next slide. This particular group of researchers pulled information from different sources around the world. And I apologize that this is quite small, but if you go to the next point, Sarah, what is in common with these different articles is that there's been this portrayal of us versus them. And that unfortunately is a common issue with ageism, as well as racism and other types of discrimination and stereotyping. It's really older adults as them versus younger people. Also, there's been a differential value placed based on age. And so when we think of healthcare decisions, when we think about who gets access to limited resources or who is most impacted, unfortunately, as this research and other studies suggest, older adults typically aren't benefiting from that perspective. And as the last point mentions, there's even this continuum for ageism. And so it goes all the way from maybe well-intentioned, let's try to protect people, they're vulnerable, we really need to do something, all the way to older adults are at the end of life, and so their end of life and quality of life doesn't mean as it does at younger ages. And so unfortunately, ageism is costing individuals, families, communities, and society a lot in terms of dollars, health, quality of life, etc. And so I think, Sarah, you're going to pick up from there.
So they just released Healthy People 2030. And within this document, it has many goals centered on reducing health problems and improving the quality of life for older adults. And I pulled out three that are relevant to our department. And so the first is increasing the proportion of older adults who have physical or cognitive health issues who are physically active. Reducing the proportion of preventable hospitalizations for older adults with dementia. And so those two are within our nutritional sciences, dietetics, and nursing. And then reduce infections caused by listeria. So this is our food safety work. Despite a growing healthy older adult population and their unique health needs, like I said in the beginning, there's not enough professionals in the workforce, particularly in healthcare, who have the advanced training in the area of gerontology and geriatrics. To address this need, Healthy People 2020 stated a goal to increase the percentage of the workforce with geriatric training. I will say in preparation for this presentation, I was disappointed to see that that goal was not carried over into the 2030 Healthy People goals. The healthcare force in general receives very little geriatric training and is not prepared to deliver health care or to deliver the best care to older adult patients. For example, the number of board certified geriatricians, so those who are specializing in working with older adults, is estimated at 7,500, which is less than half the estimated need. And the pipeline of geriatricians in training is grossly inadequate to in order to serve our growing population. So that's physicians. Nursing is also deficient in geriatric training. Fewer than 1% of registered nurses and fewer than 3% of advanced practice registered nurses are certified in geriatrics. I was unable to find the percentage of dietitians who are trained in geriatric nutrition, but I believe it probably mirrors what we're seeing with physicians and nurses. More healthcare professionals specializing in geriatrics will be needed in order to meet the demands of our older adults, both because of their clinical expertise as well as their role in educating and training the rest of the future healthcare workforce in geriatric principles. Since virtually all healthcare workers, and I would argue workers in all fields, are going to be interacting with older adults to some degree, the geriatric competence of all workforce members must also be improved more generally and through significant enhancements through educational curricula and training programs. Specific to our department, although the need is high, I believe that what research shows ageism may be limiting the number of our students interested in serving the older adult population. Research indicates that many perceive caring for and or educating older adults as less rewarding, as uninteresting, and frustrating. We can help mitigate these ageist viewpoints by being more intentional with our curriculum, being more intentional with the speakers we invite to talk with students and share experiences with, and providing internship opportunities to expose students to working with older adults. Uh, Research indicates that many students, when they're performing internships, let's take physicians and dietitians, we're interacting with an older adult in acute care setting where they are addressing an acute health crisis or are trying to better control a chronic disease state. And so this is not mirroring what we're seeing out in the community, where the active, healthy, vibrant older adult is living. And so we need to make sure that we're not just exposing students to those older adults who are in crisis health situation, but also allowing them to see what healthy aging is all about. It's also important that to acknowledge that ageist views can adversely impact the health and well-being of older adults. A recent study by the University of Michigan reported older adults who experienced 3 or more forms of everyday ageism in their day-to-day lives had worse physical and mental health than those who reported fewer forms of ageism. For example, older adults who reported 3 or more forms of ageism were less likely to rate their overall health as excellent or very good, were more likely to have a chronic health condition such as heart disease or diabetes, and were less likely than people who reported fewer forms of ageism to rate their mental health as excellent or very good, and were more likely to report symptoms of depression. According to this poll, the majority of adults aged 50 to 80 regularly experienced at least one form of everyday ageism to their day-to-day lives, and 2 in 5 experienced 3 or more forms. Many older adults reported exposure to ageist messaging. Um, and we could, changing the media's portrayal of older adults, think about your favorite shows, think about some of what we've been hearing with COVID-19. If we could reduce this negative portrayal of older adults, and we may be able to counteract the adverse effects of such messaging. Older adults also reported ageism within their interpersonal interactions. So on this form, if we look at, let's say, people assume I do not have anything important or valuable, or people insist on helping with things I can do on my own. While these, while these statements and actions may be well intentioned, they may not be harmless. Finally, some older adults themselves hold negative beliefs, such negative beliefs about aging and older people, which may partially explain why aging and age-related changes are often feared and avoided rather than celebrated. Now, Jennifer will help us start understanding how we can start reframing these ageist viewpoints.
Thank you, Sarah. And just a point I was thinking about is really we're focused on age here, and we've intentionally focused on the older part of the lifespan. Certainly, ageism happens earlier in life as well. Another important point I was reminded of is intersectionality. So when we think about aging, there are folks, as Sarah mentioned, who come from underserved groups, maybe groups that are under-resourced. And so really age can be an additive effect, and we really need to think about the complex situations of older adults. And so let's talk a minute about retirement. And if you kindly go forward, Sarah. So really, it's very interesting over time, being a grandparent, having a lot of years or even a couple of decades in retirement is a fairly new phenomenon for our society. When we think about growth and extended lifespan over life expectancy over the 1900s, we've moved from very few to, again, as Sarah mentioned, this idea of being over the hill and really what will people contribute. More recently, there's been more discussion about success in aging. As a gerontologist, some of us kind of buck against the idea of success. That would imply that some of us can be successful and other folks can't be. So really, there's this movement toward optimizing adulthood and taking a lifespan approach. And if you kindly advance, Sarah. So as we think about health span, we want to keep in mind a few facts, and we've already talked about a few, we'll hit another. We want to think about vitality, resilience. And so folks who are moving into later life, and typically there's not a one point to really think about when this starts, if it's 60 or 65. We certainly have social roles. But when we think about maybe post-retirement, we can think about some optimization. We do want to have a balanced view of aging. And so it's not that we're going to ignore challenges or say that all older adults are experiencing successful or optimal aging. So we know that there are a lot of challenges. So resources and options vary. I know Sarah's very interested in food security and insecurity. Rurality, thinking about transportation and access to healthcare, access to exercise, physical activity, fraud and abuse. We talked about sexual expression in aging, actually rising rates of STDs for older adults. Thinking about suicide rates, and often it has been the oldest old males who are white who have experienced a greater proportion of suicide. And as Sarah mentioned, ample and trained workforce. So we've got challenges, but we've got a lot of positives. So let's go to the next slide. And so related, again, to this conversation about COVID, and if you kindly advance twice, Sarah, we really want to highlight a couple of points. And so age is really a proxy. And when we talk about someone's age, we're making a lot of assumptions. And the point of the slide and the couple of messages that I've highlighted is that depending solely on chronological age is some kind of criterion for whatever we're doing related to policy, decision, allocating resources, we may not be capturing what we think we're capturing. And so as noted by the second underline, really encourage practitioners, policymakers to really think about older adults, how they vary in their needs, their risks, their ability to engage in active coping. I was just looking on a site, a decision-making tool to help older adults think about how to engage or what to engage with during COVID. And so again, this is a group, as we'll talk about, that's very diverse. So relying on age alone, chronological age, may not tell us a lot. If we go forward. So if you want to go ahead and click, there you go, Sarah, thank you. If you remember maybe one thing from the parts that I've talked about today is that the saying, if you've met one 79-year-old, you've met one 79-year-old. And Shirley Smith, who's shown here on the right-hand side at graduation, she returned to Iowa State 60 years after she graduated to complete her undergraduate degree. She and her husband moved into married student housing, and this was her retirement gift to herself and her husband's gift to her. I had a neighbor at the same time, the same age, and my neighbor would not have been interested in formal education in the same way or interacting with younger adults on a college campus. She wouldn't have had the resources to do that. So really, older adulthood is many things. So just like other times when we think about age groups or any group of people, we need to be really careful. Particularly with older adults, we could be thinking about folks who are 60, 70, 100, 110. Think about life differences. One of my favorites is McCall's Scoop, and we think about what's necessary and sufficient. We think about biology and development early in life. And then really we start to see this broadening out as that scoop opens up. Did people smoke? Did they engage in exercise? Were they emotionally satisfied? Had a cognitively stimulating job? So all of our life experiences go to make us very different in later life. And again, we also have history. So when we think about cohort, generation, and time, that's certainly contributing to the diversity of aging. Next. So Sarah alluded to this. Normal aging is different from disease. Optimal aging, and as professionals, we think about how do we provide tools, how can we help support an individual's functioning, work with that person, and think about whole person wellness. So we've got opportunities for education, technology, design, and so really getting that message across to our students, to community members, the folks that we're interacting and serving, that we all play an active role in our own aging. And so one part of being very conscious about ageism and interacting with folks is that we're working with them, we're supporting them. It's not that we're doing for them, we're doing to them. And that's often something I hear from students, again, well-intentioned, but we want to take a person-centered approach and understand what our individual goals and needs. Next. So a couple of old promotional materials we had here. We need to have another reprint. These are always popular. But I want to make this point that aging, we're all doing it. And also that it's not all wrinkles and rocking chairs. And so there's great diversity in aging. And we might want to keep another couple of points in mind. If you go forward, Sarah. So how can we promote in our curriculum, in our research, aging with purpose and aging by design? And so Sarah and I have been very fortunate to work together, at least I feel fortunate to work with her. We've had a lot of interactions, and I think it's been a great example of convergent research. So this interdisciplinary work to approaching aging, and how do we work with older adults and their ecosystem and understand their context, and again, meet them where they're at and where they want to go. Next. And there's been this recent movement that's very exciting. I've pulled a couple of slides from a recent presentation by Dr. Appleby, who's working with Patricia Diatano on this reframing activity. And so this is really what they say a generation's work. So we know that stereotypes do not develop overnight. They're not going to go away overnight. And if you kindly go forward, Sarah. This is a great example that started in one organization and is spreading to other professional organizations and units. So this is an individual, it's a group, it's a societal issue. So we need to start reframing aging. And as we've alluded to here multiple times, it can really start with communication. So being very intentional in the words that we're using, the perspective that we're conveying to students, to research participants, to folks who might be in our extension outreach programs. And if we really are intentional about how we're looking at aging, how folks are telling the story of aging, that leads to more conversation, to more thinking, And then we can move into behavior change and thinking about policy and practice. And so again, from their presentation, they had shared some ways to start. It's a fantastic website, and Sarah will kindly post some information for everyone. But they talk about some do's and don'ts and some places just to start conversation. So if we can avoid some of the things on the left, so let's go to what we could do on the right-hand side. Again, we want to think about people's context. We don't want to generalize. We want to be inclusive. We want to think about interventions and preventions. We want to focus on systems and support and really get at how ageism is working. And so rather than being sort of stuck in old paradigms, how can we advance the discussion and the work around aging? And if you kindly go next. They've got some really interesting practical guides and toolkits. This is one that's particularly helpful. What if you offered this in your class? What if you really challenged students to think about the way that they're considering development and considering the second half of life? We often talk about a tsunami, a gray tsunami. We talk about a burden in later life. But really, let's be more specific and let's be more well-rounded in how we're thinking about aging and communicating. You go next, Sarah. So a couple of examples. Sarah and I were part of a team that utilized a College of Human Sciences Teaching Initiative grant, and we did a survey of undergraduates at the time. And we had over 800 respondents across different colleges. And we looked at how much training, coursework, internship, exposure to older adults on a day-to-day basis. How much did the undergraduates report? And I'm not going to have time to share a lot of those details with you. Overall, though, College of Human Sciences students, not surprisingly and proudly, we were happy that they are more exposed to older adults, older adult curriculum. They have some more positive attitudes, but still there's much work to be done. And so in this article, we talked about some ways in which we might foster the different principles on the left-hand side. Again, how can we think about new opportunities? How can we think about design, sustainability, and taking a person-centered approach? How can we think about faculty and student professional development, like the seminar, and having conversations to dispel myths? And then importantly, as Sarah mentioned, meaningful hands-on experiences. So we tend to have two types of students who go into gerontological work. One type tends to be the student who had great experiences interpersonally. So a grandparent, typically an older neighbor, and someone who really saw that connection, felt that connection, and wanted to go into aging. For other folks, even though I had those experiences as a high schooler and earlier, I never thought about aging as a career. And it wasn't until I had an internship and really saw some potential for me and some excitement and some need and exciting questions for science and practice that I really started to think about aging as a focus for my career. So we can get those folks who are already amenable, but then how can we attract other students? How can we improve maybe their attitudes about aging and think about new possibilities? And if you kindly go to the next slide. Working with folks on campus, we've got about 50 faculty who are officially signed up as gerontology associates, and I welcome any of you who are interested in adulthood. We're focusing a lot today on older adulthood, but really thinking about adults and older adults. We've done a lot of different things to really connect with older adults, connect students with older adults. And so we've had a course offering of aging and entrepreneurship, and we're going to do that again. We're working across disciplines. We've had a learning community where we've shared across departments, across colleges, and even institutions to talk about different aspects of aging. We've worked on geron technology, which is an exciting field that has a lot of possibility. We always involve older adults and the folks that we want to design for. So, what do they want? What do they need? What do they think of the potential solutions that we're offering? How do we get students to go and visit different sites and really understand some of that context? Very fun. We've offered an intergenerational seminar. And so, when I've offered this in the past, I've had undergraduate students who may have been first or second year, all the way to grad students who were ABD, and then community members who were maybe in their 60s, all the way to the 80s and 90s. And so that's been a real fun experience. And then finally, service learning. So, how else can we intentionally involve students in a meaningful way, linking to your curriculum and the learning objectives? So, there are a lot of possibilities, and these are just a few. Okay, thanks, Sarah. Sarah, I think you might be muted.
Yep, I am. So, as our conversation is discussed today, this is providing us an opportunity, and when I say us, I mean our department, to move towards more positive aging at an individual level, and also through our curriculum and how and through our department. Some individual level action steps, just building off of what Jennifer has articulated already. We can serve as role models by using the reframing uh, techniques that we were presented, um, as and then we can also seek resources that help support and expand our understanding of aging. And as Joey indicated, a list of these will be provided at the end of today's seminar. We can also start advocating for the inclusion of aging focused work in our professional organizations. Jennifer provided an example of how, she's been working within her professional organizations. And I've worked with the Healthy Aging Division within the Society for Nutrition, Education, and Behavior to develop a society resolution to recommit to an ongoing lifespan approach and address the needs of a growing aging population in response to us, you know, um, the limited amount of aging discussion that we were having at professional conferences and what we were seeing in our professional journals. So we can all take on those individual roles. In another area that we could explore improvement or expansion rather is through our curriculum. In a recent position paper regarding the community food and nutrition programs for older adults, the Academy of Nutrition and Dietetics and the Society for Nutrition Education and Behavior recommended that food and nutrition professionals advocate for the expansion of nutrition and aging content within the current dietetic curriculum, and that we educate our nutrition students as well as current registered dietitians in geriatric nutrition and aging. We can start by reviewing our curriculum to identify the gaps related to lifespan, aging, and older adults. We could also explore more opportunities to expose our students to careers in food, nutrition, and aging, um, as well as promoting those positive aging experiences that we've talked about. And finally, while we're working on ourselves and updating and revising our curriculum to provide a better distribution of aging information, we can also encourage students to enroll in gerontology courses as electives, to attend seminars related to aging. I know within the gerontology within gerontology, there's a seminar that's offered. And we can also increase our exposure to aging by bringing in speakers who are working in the area of aging, because this it will expose students to those particular opportunities. Similar to Jennifer, I never considered working in in gerontology as a career choice. It wasn't until after my first dietetics job, when I was, working one-on-one with older adults and realizing how much I enjoyed working with that audience, and it helped dispel the myth that I had that they weren't open to making those changes. And so just those meaningful interactions can be very influential on where we go with our careers. So I'm not going to read these out to you. You can, like I've said, we'll be providing you a list of these resources, but I wanted to draw your attention to an upcoming free training opportunity. The University of Iowa is hosting an Iowa Aging Summit. This will be online and it is free. However, you do need to register for it. The dates are September 17th and 18th, and you can register for it at iowaaging.org. There's also some trainings through the Gerontological Society of America and some of the reframing resources that Jennifer used for her discussion. Here are some other resources, primarily articles that you can read as well, and this will be provided on that list. And with that, I believe we are open for questions.
Thank you, Dr. Margaret and Dr. Francis. If anyone has any questions, feel free to unmute and ask those questions or use the chat function.
Nobody included their age in the chat.
Well, I have a question, and I'll direct this to Dr. Francis. If there's really one item that you think we as a department should focus on, what would that be?
I will say the lowest hanging fruit is making sure we're not using the term elderly. I hear that a lot in my daily interactions. And so that's the lowest hanging fruit. I say the next is we really need to review our curriculum and make sure that we are addressing lifespan and not just focusing on pediatric and youth topics.
Thank you. Any other questions? All right. Well, if not, I'm sure that the speakers would be happy to answer any questions you may have via email. But thank you so much for this presentation. I think it was excellent, and as Lester says, very timely. So thank you, and we'll see everyone else next week in seminar.
All right. Thank you.
Thank you. And thanks you to Dr. Shaw for the invitation as well as Dr. Francis. Thank you.